Welcome back to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier, consisting of review articles centered on a major topic important to surgical oncologists. I'm Megan Ashdown, managing editor of the series, and today we'll be discussing the January 2026 issue dedicated to pancreatic cancer. Leading the discussion is our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of this issue, Dr. Kimberly Washington, associate professor of the Division of Surgery at Texas Christian University in Fort Worth, Texas. Welcome again, and I'll now turn it over to you, Dr. Pollack.
Thanks so much, Megan. I am so excited to be here today with Dr. Washington, who is a national leader in the management of pancreatic adenocarcinoma. Kimberly, you did a wonderful job with this volume of surgical oncology clinics, really put together, a great panel of specialists, national experts on this topic. And I just want to thank you so much. So welcome.
Thank you so much. And thank you for offering this opportunity for me. I really enjoyed working alongside the authors of this and putting this together and bringing it to fruition. So enjoyed it. Thank you so much for that opportunity.
You bet. You bet. So let's hop into this. And with your help, identified 4 articles I'd like to talk to you about today. The first one is the article by Dr. Clark on perioperative chemotherapy. I know this topic comes up a lot. I just, even this week, had a long conversation with one of my patients about the merits and shortcomings, if you will, of, going straight to surgery versus perioperative chemotherapy. So in light of this article, can you just help the listeners understand where are we at right now with perioperative chemotherapy? Should everyone be delivered perioperative chemotherapy, whether they're borderline or completely resectable? What would you consider really to be the standard of care?
Yeah, and I would say that we're actually in a really exciting place when it comes to the management of pancreatic adenocarcinoma as it relates to chemotherapy. We are pretty consistent that borderline resectable patients should receive neoadjuvant chemotherapy, whether that be FOLFIRINOX or Gem-Abraxane. That's what we typically use here in the States. But the biggest question lies in those resectable patients, the ones who are upfront resectable small tumors. Should we consider systemic chemotherapy in the neoadjuvant setting in those patients? And, I think ultimately we're going to get there, but the most recent trials really have given us some information that gives us a bit of pause. There's quite a bit of reason why we would consider giving neoadjuvant chemotherapy to all pancreas cancer patients, but I don't think the research has quite borne it out yet for resectable patients in the randomized control trial setting.
So maybe if you could just expand on that a little bit, so in your own practice, even though maybe the RCT data are not completely robust, do you routinely administer preoperative systemic chemotherapy before taking resectable diseases to the operating room? And if so, what do you base that decision on? Data, intuition, CA19-9 level. Like, how do you make that decision?
Yeah, we have a multidisciplinary tumor board that we discuss all these patients in prior to initiation of any treatment. And so it really is a group decision as to, along with our medical oncologists, radiation oncologists, et cetera. Oftentimes in small resectable patients, we do go ahead and proceed with upfront resection as long as their CA19-9 level is not extremely high and if they're in a good functional status. So in a very small tumors, the ones we rarely find, to be completely honest. However, in those patients who have a questionable functional status, we sometimes use neoadjuvant chemotherapy to kind of test the waters to see whether or not they will do well with surgery. We also, in patients who have very high CA19-9s, in conjunction with a diagnostic laparoscopy, we will often do neoadjuvant chemotherapy in order to determine the biology of their disease more. So we are somewhat selective. We tend to lean on the side of finding a reason to give them neoadjuvant chemo because I think, again, I think we're going to get the data to tell us that we should probably given it to them all. But there are a few patients that get by with upfront resection with small tumors and low CA19-9 levels here.
So Dr. Washington, so if one were to give neoadjuvant here at Ohio State, it is our preference. I'll kind of disclose that we give the overwhelming majority neoadjuvant systemic therapy. Can you take us through a little bit the choice of the systemic regimen? FOLFIRINOX, gem-Abraxane, other therapies. How do you make that decision on which
Yeah,
therapy you administer?
and yeah, that's for us. It's something again that our multidisciplinary board decides on ultimately. Oftentimes, the FOLFIRINOX we tend to use in patients who are relatively robust. They tend to be younger. They tend to in the resectable patient group. They tend to be younger. In the borderline resectable patients, we tend to prefer FOLFIRINOX, although there's not a ton of data to support that it's necessarily better. But we tend to prefer that drug combination. With gem-Abraxane, we tend to use it in older patient populations who have questionable functional status. Those tend to be the ones that, the 80-year-olds with a pancreatic cancer who we are potentially taken to the operating room for resection. Those patients tend to get neoadjuvant gem-Abraxane. So it oftentimes is a functional status thing that determines one versus the other in the neoadjuvant setting.
Yeah, sure, that makes sense. So I was going to ask a little bit about how long do you treat these patients? And typically, if you're going to give preoperative therapy, how many cycles might you be thinking of? And then also, Dr. Clark in the article touched on this, adaptive approach, and when might you, change the preoperative chemotherapy that you're given? What factors might influence that?
Yeah, that's a great question. We normally do a half and half approach, like a true sandwich, where we give about half of our chemotherapy in the neoadjuvant setting and then re-image and restage with the plan to proceed with resection. We have used a total neoadjuvant approach before when we got some response, biochemical response, and some once or twice a radiographic response. And so we wanted to continue that. And so that's pretty rare. Normally, it's a true sandwich. Now, the second question you had, specifically the adaptive approach, is a very, very interesting question. And hopefully we'll get more data in the future about that, because it's not something we've actually done at my center yet, where we adjusted their neoadjuvant chemo because of stability of disease. And that's particularly what was interesting in this article. Not so much progression. Progression gives you a reason to make a change, but they speak about how at their center, even in stable disease, they will switch their chemotherapy regimen in order to get a response. And so I think that data hopefully will be coming soon. They'll give us some information about whether or not that should be a standard practice, but we haven't actually done that at our center before. Oftentimes we'll change chemotherapy if they have progression of disease. Otherwise, we continue even in the setting of stability.
Yeah, I know Dr. Susan Tsai, who's now here at Ohio State as our chief of surgical oncology, but was at MCW where Dr. Clark was. I know that that group has really kind of, pioneered this idea of, or really popularized the idea of this adaptive therapy, and I think it's very provocative, and we're going to be seeing more in the future. One last question before we move on from the perioperative is just, so about radiation? I mean, there's been, lots of studies, and there's been kind of like a Atlantic divide. And now I think more and more in the United States, we're adopting a minimalist approach when it comes to radiation. But I was wondering what your thoughts were.
Yeah, I think radiation certainly has its uses in the neoadjuvant setting in pancreatic cancer. I think it's just a matter of selecting the right patients and us getting good data with consistent radiation therapy regimens in the study. And so that's the hard part. Operating historically, we were concerned about having to operate on these patients after radiation. I don't think that's as much of a concern anymore, as long as the timing is appropriate. But I think eventually we will identify the patients who will most benefit from neoadjuvant chemoradiation. We've done it here a few times. It's very selective, and there's something in particular we're trying to attain. One patient in particular that I can remember had some comorbid conditions that made taking her to surgery immediately after neoadjuvant chemotherapy somewhat of a challenge, and we weren't really sure if she'd ever get to a resection, so we went ahead and did chemoradiation in the neoadjuvant setting, and she got better. She like bounced back, and so we ultimately ended up resecting her after radiation. But those are sometimes the kind of random choices that we make at our center. Although I know that there are some centers in America where they use it routinely.
So we've
So,
been talking a lot about some of the advances over the last 10 years with regards to systemic chemotherapy. So now I'd like to pivot a little bit to another article by Dr. Melissa Hoag, who is, again, nationally, internationally recognized for her contributions to advancing techniques and pancreatic duodenectomy, and in particular, the robotic approach. So I was hoping maybe you could talk to us a little bit about just the robot, Whipple. Is it something that is should be done on everyone? I know in her article she talks about equivalence of open and robotic. Curious to hear about your thoughts about the kind of benefits of a robotic approach.
Yeah, I think I don't think we can say all or nothing for anything really in medicine. I don't think we can say that a robotic approach to a Whipple is always the appropriate option. There will always be people who don't fit the model. So the patients are oftentimes selected no matter what center you go to get Whipple performed. Will it become more and more standard? I think that is true, that we will do them routinely at most centers in the future. It has certainly become more common in the last 10 years or so that people are getting these done at multiple centers. And so I think it'll definitely be something that will be found throughout the country as our technologies improve. Some of the benefits, obviously, decreased postoperative pain due to incision size. I recently adopted robotic Whipples, and it is fascinating to me how small the extraction site is. Every time I do it, a 2.5 centimeter extraction site is just unbelievable when I naturally make a 15 centimeter incision to do a Whipple. So that part I think is quite interesting. I've had to take patients back, another surgeon's patient after a robotic Whipple years later, and the lack of adhesions is unbelievable. So there's certainly benefit, I believe. The postoperative length of stay is decreased in these patients. Although some of the other more concerning postoperative complications are about the same. Your pancreatic leaks and other things like that are about similar, but the experience that the patient has with less postoperative pain and shorter length of stay, I think, is worth us adopting the approach in a safe setting.
So part of the article kind of addressed the training and dissemination and the learning curve with doing robotic Whipples. I'm wondering if you could comment a little bit about, for those listeners out there who maybe don't have a robotic program, what's involved, what maybe the learning curve or things like that.
Yeah, I think the learning curve, particularly for any MIS procedure, I don't think Whipples are in any way unique in this regard, but even historically, as they transition from open coles to lap coles 30 plus years ago, that learning curve can be steep. And obviously, we don't do as many Whipples as people do cholecystectomies, and so it takes a bit longer for you to hit the plateau of that learning curve. But it's certainly important. I think what's major with adopting any type of robotic pancreas program, whether it's distal panc or Whipple, is first getting the appropriate training. And what's nice is now you're getting some of this in your fellowship training. You're seeing robotic Whipples, you're participating in that operation as a fellow, which I think is very important. And then also, once you're at a center, having someone there who is more experienced in robotic surgery and can help you along as you're learning it. So I think all of those things are important to developing a safe program, being smart about who you select as your first 20 to 30 robotic Whipples. These are not the ones who need vein resections, right? Like these are the straightforward Whipples that you're doing for ambulatory tumors or smaller duodenal cancers. These are the ones you want to start out with just to get used to the view that you're getting with robotic Whipple
Hmm.
and the suturing that you're doing in that operation. So there are smart ways to develop that program, but I think getting some good mentorship as you get started is key.
So yeah, that's helpful. I know you highlighted that, most of the data to date have shown maybe a day or two length of stay that is shorter amongst robotic Whipples, yet the overall complication rate seems to be largely the same. So, I think that provides a good transition to the next article by Dr. Burton's about management of postoperative complications following a pancreatic duodenectomy and pancreatectomy in general. Even in the best of hands, morbidity with these operations can still be high in the range of, 20 to 30% of someone having at least a little bit of bump in the road. So, in this article, I think the authors do a very nice job highlighting some of the early versus late complications of a Whipple operation. I was wondering if you could maybe just initially start off touching on like some of the early complications. What are some of the things that people need to be aware of and watchful of and be familiar with how to manage?
Yeah, I think the major one, of course, that has taken up so much of our surgical literature is the post-op pancreatic fistula, right? Like we get most nervous about that because it can spiral out of control in multiple ways. Obviously, the biggest thing about developing a pancreas program, which is one of the things that I did here at my center when I arrived, is that you have to make sure you have the appropriate ancillary staff and your interventional radiologists, gastroenterologists are very good and capable of managing some of those fistulas. Oftentimes, it's relatively rare that we take patients back to the operating room, right, for these fistulas. And so you got to have the appropriate support in order to manage them. And you have to have a keen eye. Like when things are not progressing the way that you expect them to, you have to have a low threshold to image and drain these things as well. So it's one of those things where, this isn't a set it and forget it kind of operation, particularly post-op pancreatic fistula. So you have to be prepared for that because they can go quite awry. Additionally, the delayed gastric emptying, I feel, is probably one of the other more common ones. And we have somewhat of a method that we manage that here, in that we typically will place a feeding tube. I have GI sometimes place it distally if they have some trouble with delayed gastric emptying. And I reassure patients, it's going to get better. It just takes time. And so I think that is another element in these post-op complications is first reassuring the patient, making sure that they know what's going on and that you're aware of what's going on. And then we also counsel them significantly on the front end. So those early complications in that you will see in a very typical Whipple are probably the ones I would focus the most on out of this chapter. There are some others, of course, when, if you're doing portal vein resections, you can have some early complications from that. But because portal vein resections aren't typically done in your classic Whipple, you don't see them as much.
So I was wondering, one of the other complications that was highlighted, although more rare, can be vexing to deal with sometimes, is the chyle leak. So I was wondering if maybe you could comment just a little bit about how one can identify it, when should one suspect it, and then maybe like a little bit of your algorithm for how it might be managed.
Oh my goodness, the dreaded Kyle leak. Sometimes those are worse than the pancreatic fistulas, to be completely honest. But we have a drain protocol here where we routinely place drains, and oftentimes by the time that the patient starts their diet, you can oftentimes start to see a little bit of cloudiness within that drain. We typically are pretty quick on the draw to send triglycerides from the drain fluid in order to make a diagnosis. Once that's done, I usually will give them a trial of getting to full feeds to see what happens with this output. Does it go up? Does it stay about the same? I've had it happen kind of both ways. If that Kyle leak is significant, usually more than 100 to 150 cc's a day, then I start to adjust. If we're looking at the 100 to 300 cc's a day of Kyle leakage, we can sometimes manage that with dietary adjustments without having to stop their diet. But if their output is significant, greater than 300 or so a day, then we tend to back off the diet and start TPN in order to allow it time to scar in. So that's typically the way that we manage Kyle leaks. We haven't had a significant one that's been infected or had any issues like that since the program started here. But we typically will identify them relatively early and check that triglyceride level so we can adjust our dietary needs in that way.
Thanks, Dr. Washington. And then finally, I just want to talk about one other kind of dreaded complication is like the post-Whipple bleed. And for our listeners, when someone's maybe out a week, 2 weeks, 3 weeks after a Whipple and they have a GI bleed, what should folks be thinking of? How should they work it up? And what are some of the treatment options?
Absolutely. I think the underlying thing here is having the appropriate services at your facility. This is where rescue comes into play because these patients can quickly decompensate and easily not survive. Oftentimes that if they're still in the hospital for some reason, if it happens a bit earlier, then it helps you because then they're already there, you can get labs, etc. If their drain is still in place, it helps even more because you may get that sentinel bleed where they'll have a little bit of blood out of their drain when they're previously not been bloody, which can lead you down the path of investigations. Typically, if the patient is relatively stable, we will get them down the scanner for a quick CT image. That scanner is nearby interventional radiology, so we can make a pretty easy swap. And then if there's an active bleed, then we do typically go to interventional radiology with some quickness in order to get that embolized or stented. Oftentimes, our interventional radiologists will use a stenting approach if it's a GDA bleed as opposed to an embolization attempt, just from their experience over the past many years of attempting embolization and then it failing within a few days. So they typically will use a stent. And then once the stent is placed, we typically wait about 3 to 4 days before we start any kind of antiplatelet therapy because of the new arterial stent. So that's just typically how we manage it.
Yeah, no, I think those are all great points. And I think, really importantly, as you highlighted, I think a post-pancreatectomy bleed, one should be thinking GDA pseudoaneurysm, GDA pseudoaneurysm, GDA pseudoaneurysm. And I think all of your points are well taken about trying to get a CTA and then quickly to angio for embolization or stent. So that was super, super helpful. Thank you so much. So our last article, I wanted to talk a little bit about palliative care. Obviously our hope, our desire, everything that we do and strive for is to have, a cure or prolongation of life after the operation for pancreatic cancer. However, we do know it's a challenging disease and not in a small number of patients will be faced with end of life decisions due to this diagnosis. This article by Dr. Wenkata I thought was really excellent in highlighting, palliative care and differentiating palliative care from hospice care. And there's lots of things that we palliate with pancreatic surgery. And then, sometimes we do avail ourselves of hospice care at the end of life. But I'm wondering if you could just maybe talk purely about palliation what do you see as some of the symptoms or signs that pancreatic cancer patients develop, and then what are some of the palliative approaches that we employ to help them?
Absolutely. I think the one that we see the most frequently is the gastric outlet obstruction in the setting of pancreatic cancer, especially in those patients who are unresectably diagnosed. They can sometimes be some of the more challenging ones to manage because oftentimes they present and they had no idea that there was anything wrong. And now you're telling them that they not only have um, some sort of cancer, but it's something that we can't cure. And so palliative care, I think, becomes very, very important. And I'm one of the believers that we should probably get palliative care team involved in the patient at the time of diagnosis, regardless of whether they're resectable, unresectable, or borderline. So in those patients who have gastric outlet obstruction, oftentimes, at our center, we initially go down the path of should we place a duodenal stent so as to avoid any delay in getting them to chemotherapy, since that's truly their lifeline at that point. But in some circumstances, when duodenal stenting is not an option, a complete obstruction, they can't get a wire through it, or it's at a bad angle, we frequently will have to proceed with a surgical gastrojejunostomy, or depending on the location of the pancreatic mass, if it's uncinate and obstructing the third or fourth portion of duodenum, sometimes we proceed with a duodenojejunostomy in order to manage it. So that's the one that I think we see the most frequently, although we do have, of course, a lot of biliary obstructions, but oftentimes our gastroenterologists can manage that pretty well with endoscopic drainage. It's pretty rare that we have to do any kind of surgical procedure with, unless, they have some altered GI anatomy from previous gastric bypass, but often then our interventional radiologists are able to manage that with percutaneous transhepatic biliary drain, and then later convert that to an internal metal stent. So we do actually have a lot of options that avoid surgical management in patients who will otherwise not likely survive their cancer. I think that's important because it helps with their quality of life at end of life, which I think is a major factor.
And then
So,
one other topic that was touched on was, pain management. I know Dr. Winkata, highlighted the WHO cancer pain relief guidelines and this whole notion of a pain analgesia ladder. And I was wondering if you can comment how in your practice you address patients' pain symptoms.
Yeah, and we oftentimes we see, as a surgeon, I tend to see these patients on the inpatient side. I don't frequently, especially if they're unresectable and or metastatic, I don't see them as often on the outpatient side. But on the inpatient side, we tend to have a pretty aggressive approach with pain management, especially if while they're in the hospital, we usually start out with your IV medications and then de-escalate as needed. Our palliative care team has an inpatient service as well, and so we get them highly involved with managing pain, whether that be through multimodal treatment options, which could include not only pill pain medication, but even fentanyl patches. We have a lot of different little methods that we can use in order to get their pain control, to get them home, because oftentimes that's what the patient wants, is to get out of being institutionalized with a bad diagnosis. They want to get home. And so we figure out ways in order to get their pain under control, in order to get them to a better environment while they kind of deal with the new diagnosis.
And I was wondering, do you think there's a role for celiac access block, and how often do you employ that?
Yeah, we are pretty liberal with celiac access blocks. Our gastroenterologists will do them endoscopically if patients present with a new diagnosis of pancreatic cancer. Oftentimes, they'll do a celiac block in order to determine if the block is beneficial. Their block doesn't usually last very long. It doesn't have that durability as our interventional radiologists when they do neurolysis. So ultimately, we end up with a neurolysis if they have a significant improvement in their pain. And our interventional radiologists will typically do that in the outpatient setting.
And
So,
then my final question was just about malnutrition and exocrine insufficiency. Sometimes patients can suffer from bloating and other problems with tolerating a diet. I didn't know how you handle dietary and exocrine issues with your patients.
Yeah, our gastroenterologists actually are very good. Where almost every patient with a new diagnosis of pancreas cancer gets started on pancreas enzyme replacements. Mainly because studies have shown that they have improvement in their weight maintenance, even if they don't have symptoms, even if they don't have bloating or diarrhea. And so we usually employ that pretty liberally at this institution.
So,
Great.
well, Dr. Washington, I am just so grateful for your time today. This has been a great conversation highlighting just four of the many articles that were in this volume of surgical oncology clinics that did a masterful job, highlighting the state of the art care of patients with pancreatic ductal adenocarcinoma. So, again, on behalf of the journal and myself, I want to thank you for being the guest editor and also just thank the great group of authors that you compiled to contribute to this volume. So thank you again, Kimberly.
Thank you so much for having me.
thanks for listening to this episode of the Surgical Oncology Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on pancreatic cancer, please visit us.elsevierhealth.com/expert. Surgical Oncology Clinics is available for individual print subscriptions with online access or as an online-only subscription. The series is also available via Elsevier's platforms Clinical Key and Science Direct. For more information about this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Follow us on LinkedIn at Clinics Review Articles for updates, and be sure to subscribe to the Surgical Oncology Clinics podcast on your favorite streaming platform.